Well, first I'd like to express my joy and great privilege to be invited to this colloquium. I'm very grateful to the organisers, the Chiari Institute, for inviting me. My brief is to talk a little bit about the prevalence of hypermobility and how it manifests in the general population. I'm going to take this slightly the other way around because I think it'll be more meaningful to consider what we're talking about when we talk about hypermobility syndrome, and then I'll present to you some of the very limited data we have on epidemiology. So hypermobility was really something that was known about in terms of Marfan syndrome and Ehlers-Danlos syndrome, but it didn't come across the rheumatological radar until the 1960s. And in fact, it's curious and intriguing that two separate syndromes, the hypermobility syndrome that was introduced by rheumatologists for rheumatologists, was described from the Hammersmith Hospital in London in 1967 by my former mentor, late Professor Eric Bywater, and his colleagues. I was not involved, although I was actually working at the hospital at the time. And then Ehlers-Danlos syndrome, which was described by Peter Byton, who had been a fellow with Victor McCusick in Baltimore. And these two syndromes appeared on the scene within a year of each other. And really the story of the last 40 years is how these two syndromes were described and developed and how they came to look closer and closer like each other. Peter Byton was then at St Thomas's Hospital. The Bywater's team was at Hammersmith, 7.9 miles. But in fact, on the whole, although there was such a short distance between them, they were miles apart in terms of concept of understanding and perception, because rheumatologists looked at this purely as a rheumatological disorder. Geneticists looked at it rather more broadly, as you would expect, and they saw the bigger picture. We've heard quite a lot this morning about the Byton 9-point scale, which is illustrated here. I just want to introduce a note of caution about the use of this as any kind of indicator of hypermobility in practical terms. It was never meant to be a clinical tool. It was developed by Peter Byton for epidemiology work in Africa, for which it was very good. It's a screening test, but it doesn't really tell you very much about hypermobility, and certainly it's not very useful as an index of the quantitative nature of the condition. For instance, it doesn't actually tell you whether people are more hypermobile or less hypermobile. All it does is to indicate a number of joints that happen to be involved in that subject. And from a very limited number of 5 joints in the body. So I would urge caution in its interpretation. It is not suitable certainly for diagnosis of hypermobility syndrome or for EDS in that matter, but it's one piece of a picture that we draw together as part of the syndrome. Now the syndrome of hypermobility syndrome had a very simple concept. It was the occurrence of musculoskeletal symptoms in the presence of generalized joint laxity in otherwise normal subjects. Now that was, I think, misinterpreted over the years, because I think what they meant at the time, although I didn't ask them, I can't be sure about this, is that they meant that there were no other rheumatic diseases. There was no Still's disease or chronic idiopathic arthritis that they could find, and these were otherwise rheumatologically healthy. That has been taken to mean that these were actually healthy subjects. In other words, these were people whose in every other respect, other than they happen to be at the upper end of a spectrum of normal joint mobility in a population, were normal. And that has stuck. What is rather annoying is that they actually considered alternative suggestions, alternative interpretations, that in fact they might be looking at something like EDS, or as they put it here, this is the actual quote from the discussion of their article. So that's rather stuck, and it's rather stuck into the thinking of rheumatologists in particular, and it's been very difficult. And in fact, it's taken 4 decades to even move that concept, as if it's been embedded in concrete. Now, I came in on the scene in 1970, and I started looking at this from the point of view of skin. I was given a task of measuring skin in scleroderma, and what I stumbled across by accident was a way of measuring the elasticity of skin in vivo. And that has taught me and shown me, and I'll show you in a moment, how skin stretches when you stretch it in vivo. And there's something showing that, shouldn't we? Can I get rid of that? I hope so.
Okay.
Let's have a look. Just want to get rid of that. I just want to get rid of that. Yeah, okay. Yeah, this was a graph that came from my studies at that time, comparing skin in Ehlers-Danlos syndrome from control subject. And what we showed in that study was that skin behaves differently, not just quantitatively, but also qualitatively. It stretches in a different way. I think when people look at skin for stretch, they see how far it stretches, not necessarily how it stretches. And one of the things that I noticed was that when you take skin, a fold of skin on the back of the hand, and you just pull it away from the back of the hand, it starts stretching all the way around the hand and even up to the wrist. Now, the next slide, I wonder whether we'll get some success with this. No, wrong. The difficulty is to move the cursor. I've lost it. Here it is.
Yeah.
Before we get the video,
Tap on the screen, maybe?
it's up there. It's up there. The arrow comes there.
Just tap on the screen?
It's about there. Well, it's not showing.
No.
Okay, we'll leave it. We'll move on. That's okay. So, skin was behaving differently, and I can't show you the video, but what it shows is that when you pull the skin up where the thumb and finger are now, you actually see the bracelet move down towards, it's actually being stretched, the skin underlying the bracelet is stretching, so it's actually moving the bracelet, but you won't see that, unfortunately. Then it became apparent that there was more going on in skin stretch and hypermobility in these patients with what we call hypermobility syndrome, because there were tantalizing pieces of information suggesting that some of them actually had marfanoid changes. That's a different ballpark altogether. Once you introduce marfanoid changes, you're looking at a connective tissue disorder. That came on stream about 1981. So we're beginning to look as if hypermobility syndrome was looking more and more like hypermobile EDS, with overlap features with some of the other major diseases. Marfan syndrome with Marfan habitus, but without the aortic dilatation or ectopia lentis, stretchy skin, scarring, without the more serious problems associated with vascular and classical EDS. Osteopenia, indicating perhaps an overlap with osteoporosis. And as the syndrome became more structured, we could see it was not just about hypermobile joints. There were features in the skin, features in the skeleton, and then there were other features in the supporting structures of the body, the abdominal wall, the diaphragm, etc. showing that we're looking here at a much broader picture of connective tissue disorder than purely hypermobility. But nevertheless, talking to one's colleagues who were very focused on the idea of this being normal people, see, the people who complained of symptoms, whether they were orthostatic intolerance or chronic pain, they were dismissed. You can't have that. You don't have those symptoms if you're healthy subjects. And this has been the lot of many people with hypermobility syndrome, and still pertains to this day. That's why we introduced in the late 90s the Brighton score, the Brighton criteria, I mean. Now this was okay, it was a little bit like the other criteria, Berlin and Villefranche, that had been, and I suppose you could say we were sort of copycatting a bit. But what we intended with this was to draw together all the features of the syndrome that seem to be part of the syndrome, whether it's dislocations, whether it's soft tissue injury, whether it's phenotypic features of Marfanoid habitus, skin stretch and so forth. And these were published in the year 2000 and have been around sufficiently long to have had some experience in its use. So it's like the others, using major and minor criteria, but it goes beyond having just the Brighton score, or didn't abandon it, but it incorporated it, and pain in joints to include other features. Now, looking at the development of the phenotype as it appeared, going back to 1967, when it was purely musculoskeletal pain and joint instability, we find we go on a journey which took us through areas that we never dreamt we would be thinking about, so that following the overlap, we found, not we, but I mean it was established that pelvic floor weakness became a major problem, chronic pain in the 80s and 90s, chronic pain, as it were, not just traumatic pain or the effects of trauma, but the descent of a whole tier of chronic pain, often referred to, particularly in this country, as fibromyalgia, became one of the really major problems and led to a lot of the other complications that followed suit. The interesting work from Spain in the 1990s showed an association, a statistical epidemiological association between hypermobility on the one hand and certain psychiatric disorders on the other, mainly forms of anxiety, panic attacks, and phobic states, particularly claustrophobia. And then shortly on the tail of that came, in the 1990s, the realization with Peter's revelations relating to dysautonomia, and that's been followed up with the hypermobility patients too. And GI dysmotility in the late 1990s hit the scene, as it were, and revealed a whole range of panoply of gastrointestinal problems, attributable mainly to dysmotility, but disordered physiology affecting everything from the esophagus to the rectum. And then I put at the bottom here something that really only hit us in the early years of this century, that many of these patients were becoming progressively disabled, physically and psychologically disabled. And this is not to mention all the neurological problems that are the subject of today's discussion. So one of the things I've been able to do, because I've been following patients over these years, is to try and describe the natural history of the condition. Because the condition was a moving target, we were learning about new complications by the decade. And I'm sure it's not finished yet. So So I've analysed this into three major headings. One is the obvious one, which was known about from the early days, the biomechanical effects of tissue laxity, presenting with non-inflammatory joint and spinal pain, joint instability leading to dislocation and subluxation, a vulnerability to soft tissue injury, affecting ligament, muscle, tendon, enthesis injury, and overuse injury, and postural problems and mechanical problems like flat feet and spinal disorders, as you've just heard. And to add to that, one could include the pelvic floor difficulties, the weakness, the rectocele, cystocele, prolapse, and other things like hernia and varicose veins were added to the list. Then that would be the initial phase of the condition, perhaps starting in childhood and getting worse in adolescence, and into the second and third decade they would tend to get this second tier of symptoms, superimposed on the first tier, pain amplification. I mean that pain became a major life-dominating factor in their lives, pain that's often unresponsive to analgesics, even opiates. We started to talk about kinesiophobia. Patients would avoid movement because movement was painful, so they wanted to avoid it. So they tended to do less and less physically, and as they did, their muscles got weaker and their joints got more unstable and would become deconditioned. So this widespread chronic pain, which is the term we tend to prefer in the UK, but you call it fibromyalgia, that's fine, became a real problem. And the interesting thing was that the rheumatology fraternity seized on fibromyalgia and made it a different disease. Well, in the same way as we heard this morning about chronic fatigue being designated a distinct disease, as Peter said, many of these patients are hyperproportional, hypermobile. So there's a great overlap here. And fatigue indeed becomes a major problem. Well, whether it's due to the EDS, whether it's due to the chronic pain that is associated with EDS, or whether it's part of the autonomic dysfunction, it's quite likely, in my opinion, to be a combination of all three, and possibly other factors as well, including sleep we've heard about, or lack of it. And then we have, including in the second tier, the advent of orthostatic intolerance, postural tachycardia in particular, which we find, as you do, to be extremely common in patients. Almost inevitable sooner or later that they get POTS, even if it's symptomatic or not, and it isn't always symptomatic. And then there is the psychosocial toll of this, all this symptomatology and morbidity. It takes its own toll: anxiety, depression, obesity, inability to work, isolation, and sadly despair. So I've tended to call this entity, well, it's a kind of subheading, if you like, the new rheumatological disability. When I started out in rheumatology, we used to see patients coming to clinic in wheelchairs because they had rheumatoid arthritis that had destroyed their joints. We don't see that anymore, fortunately, but we certainly see patients coming to clinic in wheelchairs and unable to stand unaided. Some patients haven't been able to stand for years when we first see them. This is a terribly badly neglected disease. These people are often severely physically disabled, but what is unusual about their disability, it's a physical disability, but their musculoskeletal system is largely intact. They have no functioning nerves, muscles, joints, and bones, but because of the pain, presumably, they are unable to use them. And this is what we find: chronic pain, as I said, unresponsive to analgesics, and on top of that they have the toll of these other systems that have now become a regular part of the scene. They're mostly, we were talking about this a moment ago, they're mostly young, highly motivated people, achievers, often because of their hypermobility, sports, music, dance, highly talented, but cut down in their prime and because of this condition. And they're often told it's all in the mind, which only makes things so much worse, because it's almost accusing them that they're faking it. And we even see worse than that. We see parents who are accused of suffering from Munchausen's by proxy because they're not they're held to be responsible and sometimes taken into care because of this alleged factitious disease. So these patients are often felt dispirited, abandoned, and angry. And in some cases, they've given up hope altogether. There is a solution to their treatment. We found we're beginning to make progress. Intensive physical rehabilitation. It's not any old physiotherapy. It has to be adapted to the needs of patients with lax and fragile tissues. Their tissues are very vulnerable. They won't stand pommeling and excessive exercise until they're ready for it, till their muscles have recovered and are strong enough to proceed to the next stage. It has to be sequential. We use pain management using CBT methods and found it to be helpful. Patients learn how to handle their pain. We can't cure it, but they manage it in a much better way, and it has less adverse impact on their lives. And we now have dedicated programs in one or two of our centres that offers this combination. Only started 3 years ago, and almost ground to a halt because of the overload of need of pressure of patients from all over the country queuing up for very limited services. And this is another video that I wanted to show you, but I don't think I can. But this merely shows this young lady getting up from her wheelchair with great difficulty and walking across the room with a stick. There's a lack of interest in hypermobility and EDS, I have to say. Particularly, rheumatologists are probably fairly near the top of the list. Epidemiologists have been pretty much there too. I say most doctors, but not geneticists, I hasten to add. Physiotherapists are pretty good at recognizing it, although they don't often know necessarily what to do with it. There's a lack of awareness and knowledge, and the patients get a raw deal, and there's a vast mountain to climb with education, which we're just beginning to realize. So in 2013, we're looking at a syndrome that is related almost certainly to connective tissue matrix proteins, which is genetic in origin, although the main genetic cause for the bulk of patients we see has not yet been determined, although there's a lot of work going on this at the moment. Consequences as far as the musculoskeletal system is concerned are largely biomechanical, as I pointed out, and the pathology is often seen to be that of trauma and overuse. Wide-ranging musculoskeletal features, we see a range of neurophysiological defects, proprioceptive impairment, enhanced pain perception, resistance to local anesthetics, which is not widely known, and autonomic dysfunction. Genetic link to anxiety and phobias. We talked about briefly the gastrointestinal problems, which loom large. It's a complex disorder, it's unrecognized, and it's sadly misunderstood. I called it a rheumatological disability, but it goes far beyond the musculoskeletal system, and we've no right to call it rheumatological anymore. So we had these two diseases, and as the time went by, we found that they looked more and more similar to one another. The autonomic was on both sides, gastrointestinal was on both sides, and it was Brad Tinkle here who in 2009 called a halt, as it were, on these two disparate streams of thought, not really exchanging information with one another, and said, this has got to stop. He didn't use that language, but I think that's what he meant. He brought a handful of us, 6 I think, together to write a statement in which we said we can't, we put our hands on our hearts and we say we can't distinguish anymore between what you rheumatologists call hypermobility syndrome or joint hypermobility syndrome and what you geneticists call Ehlers-Danlos hypermobile type. We can distinguish them from other forms of EDS and other connective tissue disorders, but we can't distinguish them from one another. So what was important, I think, about this statement was not just that, hey guys, we've got to do something about this. It made a further statement. It said, whatever you call it, it doesn't really matter what you call it, but these patients need treatment, and that's where we should focus our energies. And that was important, and thank you for asking me to take part in that. So we've done all this. I want to say now a little bit about the epidemiology, because I promised it. One study I was able to do in 2003-4 was to look at 500 consecutive rheumatology referrals to a general rheumatology clinic in a district hospital in northwest London. And although I looked at the rheumatological problem, I also scored them for the Brighton criteria and came up with a clinic prevalence for the joint hypermobility syndrome, as we call it, in a random, unselected, consecutive group of 500 patients. And I had a feeling it was quite high, the prevalence was going to be high, but was not really prepared for what I found. We found that the overall clinic prevalence of new patients was in the order, well, it was 45% of all referrals to a rheumatology clinic. And the other thing that was interesting, which you see on this slide, is that gender and ethnic origin were relevant factors, and that if you just took Caucasian males, because we were able to divide people into whether they were Caucasian or non-Caucasian, we couldn't, the numbers weren't big enough to split them down into different ethnic groups. But what we did find that Caucasian males were 20% or just under, Caucasian females were 40%, non-Caucasian males were also 40%, but non-Caucasian females were over 60%. So clearly it's very much, it's very common amongst this population of rheumatology patients. Okay, what we did then was to extrapolate. Always a very unwise thing to do, I know. But if this is the population in a clinic of rheumatology in one hospital, what's it like for the country? And how does it compare with what rheumatologists think the number of patients they see? We did a survey, happened to have done a survey just prior to this, of about 250 rheumatologists in Great Britain. And the mean number of cases they thought they saw was about 10 a year. In fact, they saw many more than that. I think it's on the slide. They actually saw 224. So they were missing about, this is theoretical of course, about 95% of the cases. So it's not a good thing to be diagnosed by an English rheumatologist with hypermobility syndrome, because they're going to miss all the vast majority. Now this is not just a London problem or even a Great Britain problem. I'm sure this is a worldwide problem. Because wherever I go, I find that the interest and the knowledge about the syndrome amongst my colleagues is very minimal, and it's in all continents, and that's a fact. And another interesting piece of data here is when patients were asked how long it took them to be diagnosed. You'll see that 52% of this series of 138 patients taking part in the survey, when asked how long did it take you to get diagnosed, said it was over 10 years. So that says something. Now, finally, I just want to conclude with an epidemiological study, which I think is very important, which has only been published in the last 3 months. As I said before, the rheumatology epidemiologists have a fine reputation in the UK for doing splendid work in rheumatoid arthritis and other diseases, but they've never touched hypermobility. They've always found a reason for not doing it. And this is the first epidemiological population study of hypermobility that's been done by a group such as this. And what they did, they didn't use the Beighton scale. I'm glad. They used what's called the 5-point questionnaire, which is something that, which is a self-reported questionnaire, which has been validated, and it asks 5 questions of the kind of things you might expect hypermobile people to be able to do. Can you place your hands flat on the floor? Well, you know that one. And the first 2 come from the Beighton score, but the others are, as a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? We had a whole range. We started with 10, and we looked at them statistically and compared them with controls, and found out that 5 of them, these 5, stood up to the test. So we've used these in a number of studies, including heredity studies, in twins, for instance. And it is actually, it's a proxy for hypermobility, which means that if you have 2 or more yeses, there's an 85% sensitivity and a 90% specificity for hypermobility. So what this study found was that out of 12,000 people who were questioned, I must say that they only looked at hypermobility using this study, and they looked at pain. They were interested in pain, but they weren't interested. In many ways, it's not a good paper. They don't talk about hypermobility syndrome. They don't talk about EDS. They don't even mention any of the things that we've been talking about. But they did find that overall, well, looking at hypermobility and widespread chronic pain, chronic widespread pain, that 3% of the population probably had hypermobility and chronic widespread pain. Well, if you've got patients who are hypermobile and have chronic widespread pain, it's quite likely, I would say, that they've got what we're talking about here today. So this is the beginning, perhaps, of an era of epidemiology where we can actually answer the question that's been posed by the title, to suggest that it's much more common than people give credit to. And I think when it's suggested that EDS has a prevalence of 1 in 5,000, this is 3 in 100. So it's a big gap that needs to be addressed. Thank you.
Thank you very much, Professor Grahame. I have one quick question while you're just in it. What are CBT methods that you...
I'm sorry, it's a form of psychological approach, cognitive behavioral therapy.
I see.
I should have spelled that out.
Okay. Dr. Benson?
I don't know how much time we have, but
We don't, but go ahead.
okay. I'm a spine surgeon, and I look at the angle of chronic pain from a slightly different perspective. We see it quite frequently in that patient population. Of course, there's GI pain, pelvic pain, temporomandibular joint pain. Chronic pain is estimated to be about 20 to 30% of Americans, at a cost of about $650 billion, which is a year, which is more than we spend on heart disease or more than we spend on cancer. And yet we don't have a good handle on it. And you're talking about another subset of the population, I think. Or are you suggesting that there may be a hypermobility component to all people with the chronic pain syndrome, which has a sleep disorder, a fatigue component, and a multiple unrelated somatic complaint component to it?
I do, and I think it probably includes the cervical instability component as well. I think it's a very broad brush syndrome. It's difficult to grapple with, but I think what we're seeing is something that touches almost every specialty in medicine.
So you alluded to your what I would call a chronic pain team. I'm assuming there are psychologists, psychiatrists, physical therapists, and other people who work with them. We need more of these people and more of these teams, and we need to identify these syndromes because people are being inappropriately operated on, inappropriately managed, and misdiagnosed. How do we as a society, a worldwide society, come to grips with this?
Well, it's not too difficult to diagnose EDS if you know how. And I think looking at the chronic fatigue population, looking at the gastroenteritis, 50% of patients with irritable bowel syndrome are hypermobile. That's a very big population. And it's a big, it has ramifications in almost every area you care to look. We just haven't started to look.
Is there any way we could give a name to this? That the problem is that there's so many different. You need so many different people and so many different specialties to take care of it. Can we not give it a single name so that we can then study it better? I mean, if you get somebody interested in doing a study on joint hypermobility who's actually a pain specialist or doing basic science research on this, the basic science research on this is really is lacking pretty terribly too.
Well, what we lack, perhaps most of all at the moment, is a biological marker for the syndrome. Clinically, we have to rely on clinical methods of diagnosis, and I don't think it's that difficult. The problem in the past has been that people just don't look for hypermobility. Or, in the case of rheumatologists, they do look for it, but they don't know what to do with it when they've found it, because they will say the patient has a degree of hypermobility. But they don't know what to do with it. They don't make a definitive diagnosis. Having worked in hypermobility syndrome, I now feel it's not a term that we should use anymore, because it's so much more than hypermobility. I like EDS.
Well, in looking at biomarkers, looking for biomarkers of this, that there seem to be two that have been shown in a research capacity. One is functional MRI in pain, and that they show clearly different patterns of response to painful stimuli on functional MRI. And as I understand it, there are several studies which show that the inflammatory markers, which are not present in the systemic circulation, can be present in the CSF. Are you familiar with that word? So there can be biomarkers of these conditions. I think the ones that would be most likely to be valuable would be the ones that involve functional MRI.
We're also, of course, very keen on the genetic markers, which we hope will come on stream quite soon.
They must be nearby in the genetic data.
There's a lot of work going on in this area at the moment.
Yeah, I think it brings up the difficulty of, separating the EDS, which may be a large center, from back pain and other things. The MRI stuff has to do with back pain, and would you consider that part of EDS or not? But any kind of pain syndrome, and this hopefully would be a little more of a subset of patients anyway. I think the spinal fluid markers, substance P levels and things like that are documented in the spinal fluid, again, are probably maybe more specific to this central sensitization issues and pain in general of whatever etiology. And I guess we'd like to think that everybody that has pain, it's not just that they have EDS, there are probably, I'm sure other causes, but this is certainly a large ignored population of patients that are poorly understood.
I mean, of this 500 patients, 45% complied with the criteria, but they came up with back pain or neck pain or a variety of different syndromes.
Thank you, Ken.
I'm sorry.